Hello everyone, I'm Phil Diamond, the spokesperson at the U.S. Embassy, joined today by Dr. Alex Ario, the director of the National Public Health Institute. Welcome, Dr. Ario.
Thank you very much.
Thanks for joining us. And we're going to begin with the first question so we can hear a little bit about your work. Can you tell us about the National Public Health Institute and what role does this program play both in Uganda and the region?
The National Institute of Public Health is actually an integrated disease control center for the Ministry of Health, which was started way back in 2013. So the Ministry of Health then set up to consolidate its public health functions by developing a National Institute of Public Health with very clear strategic objectives of integrating critical disease control operations, streamlining coordination, detecting public health events early, and then responding to them rapidly and effectively. So the Director General at that time, who is actually currently our Honorable Minister of Health, Dr. Jane Ruth Cheng, came up with this vision and consulted USCDC. So when she consulted USCDC bought the idea and then decided that we pay a visit to Atlanta. So when we went to Atlanta, we learned a lot from Atlanta. And after that, we came back and then formed the National Task Force for the formation of the National Institute of Public Health. And then we started the process. And the process was supported wholly by US government through CDC and International Association of National Public Health Institutes. They provided a lot of technical support to us, which made us actually achieve what we have achieved to date. So with support from the US government, we have managed to implement almost all components of the Institute. The Institute is actually composed of different directorates. And with support from the US government, we managed to implement them in bits. But now, with the directive of the President, which came out at the beginning of this year, we have now set out to form the Institute as an autonomous body of the Ministry of Health through an Act of Parliament. So it is going to be formed by a statutory instrument that is going to make it autonomous, so that it's able to solicit for money, but also able to run its own programs without interference from others. And all this we have achieved with support from US government through USCDC. So when you look at the Emergency Operations Center, it is part of the Institute. The National Health Laboratory Services in Butabika is part of the Institute. In fact, our campus is actually in Butabika, where the lab is. So to date, we have actually registered a lot of successes in addressing global health security agenda and scaling up international health regulation capacities to prevent, detect, and respond to public health events. Even in the face of continued threats like Ebola virus disease, like COVID-19, like many others, we are actually very ready to respond to these public health emergencies. So this we do it through collaboration between all the arms of the Institute, and this has strengthened our epidemic preparedness and response. There is very good coordinated, organized multi-sector response to public health emergencies. Unlike before, where things were done more or less like firefighting. You do not know who is going to the field, you do not know who is bringing what, but now we are able to track all the contributions of all partners. We are able to know, and the leadership of the ministry has made this work very well through the Institute. We also receive and share information very appropriately, timely, and complete information. So this actually has happened because of the investment which has come into the Institute by US government. Detection, confirmation, and response to public health emergencies is done within 48 hours of alert. Something which many countries have not managed to achieve, what we have achieved. And this one, we've done it because of a robust laboratory testing capacity. All this because of investment, the USCDC, an efficient sample transportation network. If you remember, the sample transportation network started with EID, early infant diagnosis. But now it has expanded to many things, including outbreak samples, which we actually use the sample transportation network. Similarly, diseases are actually controlled at source based on epidemiological evidence. And this is because of an effective national rapid response team, which is heavily supported by the Public Health Fellowship Program fellows. So fellows actually go into the field within the shortest possible time, even before the National Task Force has met and made a declaration. Because the minister can call and say, there is an outbreak, so we need the team in the field. So we are actually ready 24 hours. And we are able to deploy in the field without any bureaucratic hindrances. And then of course there is real-time surveillance of both endemic and epidemic-prone diseases. Because we have very robust system of surveillance, we have the DHIS too, and all this has been supported by US government. And then of course policy decisions by the Ministry of Health is informed by evidence. Because we provide evidence, it's no longer where we rely on generic information from textbooks, but we now generate evidence which actually direct our interventions as Minister of Health. So in summary, there is faster, smarter, and more efficient and effective prevention and detection and response to public health emergencies because of the Institute. So we now operate as one. So all we're remaining with is simply legislation so that we can now perform our functions better. Yeah.
So you talked a lot about the Institute, and towards the end of your response you touched on the Public Health Fellowship Program. I'd like to talk a little bit more about that. Can you describe what that Public Health Fellowship Program is, how the U.S. government is part of that program, how it partners, and the role that the Public Health Fellowship Program plays here in Uganda?
The Public Health Fellowship Program is actually the capacity building arm of the Institute. So right from the design stage of the Institute, the thinking behind it was that we need the capacity building arm with different tracks. So different tracks which we identified, which we needed to build the competencies so that the Institute is kind of self-sufficient in terms of the technical capacity. It was in field epidemiology, was in laboratory leadership, was in health informatics, was in prevention effectiveness, which is many people know it as health economics, and then monitoring and evaluation. So those are when you look at it, is basically when you looked at the spiral progression of public health interventions to control a public health problem or address a public health need. When you look at it, you need to look at it from generating evidence, finding out where the problem is, generating evidence, and then supporting that evidence with diagnostics, and then putting in interventions which are cost effective, and then you monitor what you're doing. So basically we looked at all those tracks of the Public Health Fellowship Program to address those areas. Now, because this involves heavy investment, the decision which was taken by the Minister of Health, of course, with the consultation with CDC, was that we needed to face this. So then the decision was made that we start with field epidemiology. So the field epidemiology training program, which is currently operating as the Public Health Fellowship Program, is a very unique one. It's actually a postmaster's program. So the Advanced Field Epidemiology Training Program is a postmaster's program, which is the first of its kind in Africa. And it has achieved a lot. So it's meant to build capacity through training in service. The design of the Public Health Fellowship Program is basically to support the public health sector. It's not to support the private health sector, so the public health sector. So these fellows go through a rigorous process of selection. So as they go through this mentorship, and then they are also implementing certain projects. So the projects which they're implementing allow them to attain key domains. So the key domains that they attain is basically response to public health emergencies, and then public health surveillance, and communication, public health leadership, programming, health programming, which is basically cost analysis of outbreaks, and then quality improvement projects. And then we have also introduced another concept, which is burden of disease estimation. So when you look at the design of field epidemiology training programs around the world, Public Health Fellowship Program is the only one which is unique, where we have cost analysis of outbreaks, where we have a quality improvement project and burden of disease estimation. The other field epidemiology training programs don't have it. So when these fellows are there placed within programs, the fundamental role is that they are the first responders of the Ministry of Health when there's a public health emergency.
So you talked some about the fellows being first responders for various public health emergencies here. Could you tell us a little bit more about some of the particular work that fellows have done here in Uganda and the impact that it's had? And also, given that COVID-19 is dominating the headlines right now, how have fellows potentially contributed to the COVID-19 response here in Uganda?
Fellows have implemented a number of projects. So field projects, total field projects implemented to date are actually 335. And that includes 111 outbreak investigations, 13 emergency investigations, 77 surveillance projects, 103 applied epidemiological studies, and then 4 cost analysis of outbreaks, and then 30 quality improvements. So all these are quality work which has been done. So many of the things that fellows do, there's no research in it. They actually literally non-research. Is to address public health needs of the country. So the design of the projects that they do, we ensure that it is not geared towards research, but to address public health needs. So there are a number of outbreaks that the fellows did, which have actually contributed to control at source. The example I can give is yellow fever outbreak, which we did investigations in 2016, which actually led to control of yellow fever within 12 days. Fellows have done a number of foodborne outbreaks, which led to control, generated evidence which led to control of the foodborne poisoning on time. I can give examples of cholera outbreaks, which has happened in many parts of the country, and fellows managed to generate information that made it be controlled on time. We had food poisoning in Sironko, where it was organophosphate poisoning. Then there was another organophosphate poisoning in Tororo. Fundamentally is the control of these outbreaks, on time. Fellows have done a lot of work on measles, which generate information that actually even led to change of policy in the country. Fellows have done a lot of work on malaria, which has led to control of malaria and change of certain approaches to control. So a number of these has worked, and then when you look at the quality improvement projects that fellows have designed, has helped improve on the surveillance system, has actually helped in redesigning some of the surveillance systems, like typhoid fever, which were actually false alerts. They were actually false cases. So there was actually overdiagnosis of typhoid. So when fellows did the work, it has actually made people realize that, and that has been actually corrected. Right from when COVID-19 was announced as a problem, before even announcing it as a pandemic, the country actually activated the Emergency Operations Center at the National Task Force. And right from that time, the program has been at the center of the preparation, first of all. At the preparation, we managed to support a number of the activation of district task forces. Fellows have done that. Fellows were instrumental in screening at the airport. Fellows have been instrumental in the investigation of cases. Now that is at the time of declaration. So fellows have been at the center of the case investigation. Fellows have been involved in contact tracing. So they have actually been involved in many of the things at the point of entry, at the districts, supporting districts, in setting up the community-based surveillance systems. Fellows are actually very much involved. So in terms of preparation for COVID-19, which rolled over from the Ebola virus disease to COVID-19 to the declaration of an outbreak, fellows have been greatly involved together with the supervisors of the Public Health Fellowship Program. The case investigations that we've done, coupled with the rapid assessment for community transmission which has been done in Uganda, we have sporadic cases, but we don't have any sustained community transmission.
Mm-hmm.
So because of that, we can deduce that what we did at the airport to intensify screening, and then of course the decision that the government of Uganda did after declaration by the president of the lockdown, we think it probably slowed down the transmission, which was actually very helpful. But nonetheless, we managed to generate a lot of epidemiological projects which fellows are currently doing in different stages. So some of them are looking at the behaviors of the people. Some of them are looking at adherence to prevention measures. Mm-hmm. And all this should be able to help the public to actually prevent the transmission. So for me, the appeal to the population is that COVID-19 is real. It's a problem. Much as the measures have managed to make it be contained, we should not take it lightly. We should continue with the control measures. We should actually observe the hygiene, continue the hand washing, continue the physical distancing, continue staying at home until we can have enough evidence that easing the lockdown is the best thing to do. So I think, to me, the appeal to the population is that we need to be vigilant and report anybody that develops symptoms that could be COVID.
Well, thank you so much, Dr. Ario, and we look forward to continuing the strong partnership.
Thank you. Thank you very much.